Hi everyone, it's Gavin J, the best thing since the colour brown. And you're listening to Therapy Suite right here on UK Health Radio, the world's #1 talk health radio. This week, I speak to consultant neurosurgeon Dr. Jeremy Rowe about the brain and related issues like brain tumours. Welcome to the show, Dr. Rowe. How are you doing?
Very well, thank you.
There's a little pause there. Thank you so much for taking the time. I know you're very busy, but it's such an interesting subject. I wanted to start off by just asking you a bit about your background and how you kind of got to where you are today. You know, I think it'd be quite interesting for our listeners to know that.
Well, kind of think that most careers evolve a series of experiences. And I originally trained in neurosurgery in Oxford. And during that training, I developed an interest in what was termed stereotactic surgery, which was the use of frames and guidance systems to help neurosurgery and neurosurgical operations. Because of that, and this is now more than 20 years ago, I then decided to move to Sheffield, specifically to develop an interest and practice in gamma knife stereotactic radiosurgery. This is very much a complementary practice to the stereotactic neurosurgery, but it was different. And Sheffield at the time was one of the few centres that was able to offer those facilities. Sheffield originally has a place in the world history of gamma knife radiosurgery. It was the third unit to be created in the world, and the founder, neurosurgeon David Forster, actually worked with Lars Lexell, who developed the gamma knife. So I moved to Sheffield largely because I thought that gamma knife radiosurgery offered a better option for certain patients and certain conditions. And it's attractive because it's minimally invasive. It puts a patient through relatively little. And over the subsequent years, that's become increasingly accepted. And with that increasing acceptance, the practice has grown. I've got no idea. I probably should try and work it out sometime, but I've certainly done several thousand gamma knife cases. Saying that the practice has grown, it's still quite a specialist practice. There are now 7 working gamma knives in the UK. And about 3 years ago, Amethyst took on responsibility for the administration of 2 of those units. The unit formerly at the National Centre for Neurological Disease, or Queen Square in London, and also the Thornbury Gamma Knife here in Sheffield. And I think it's fair to say that Amethyst have been enthusiastic in their support for gamma knife treatments, and it's really because of their interest that we're having this conversation tonight.
Brilliant, brilliant. Tell us a bit more about the work that you do with Amethyst.
Right. Well, thinking about this, I would divide the indications for gamma knife radiosurgery broadly into 3 categories, but they then subdivide and get more and more complicated. And the 3 categories that I talk about are tumours, vascular malformations, and functional indications. Now, tumours, and I kind of get the impression that that's where most of this evening's discussion is going, range massively, and they all get termed brain tumours. But within that range, there can be very, very slow-growing, indolent, benign lesions, and there can be very, very aggressive, malignant ones. So I think the point about that is that patients need to be able to access the information that is specific for their condition, and that we shouldn't generalize too much for fear of causing confusion. The second broad category would be vascular malformations. Now, they're not tumours. They're tangles of abnormal blood vessels. And with those blood vessels, they have a tendency to bleed and can cause strokes. So the object of radiosurgery and other treatments is to obliterate and close down those abnormal blood vessels and prevent strokes from developing. The third indication is what I would term functional. And I define that as trying to make a lesion to suppress abnormal neural activity. Now, that's not widely practiced or commissioned in the UK with the Gamma knife, with the exception of trigeminal neuralgia, which is a severe facial pain. People call it the suicide pain. And what you're trying to do is suppress that painful sensation. Now, I think your original question touched on risks of treatment, and that depends very much on what you're treating, how big it is, where it is. But as a generalization, and it becomes specific. So if we were treating trigeminal neuralgia, I'd say the only risk is could we cause facial numbness? And most of the time with numbness, patients are happy because the pain's gone. But the numbness can be a problem. Other indications differ, particularly with mass lesions. It depends what the lesion is, where it is, and how large it is. But overall, swelling reactions, delayed reactions, I'm going to say less than 5%, probably much less than that. And that probably compares very favorably with open surgical procedures, which are obviously much more invasive, with potentially more serious associated risks.
And before undergoing that kind of surgery or treatment, does the person need to be assessed to see how safe it is to carry it out on them?
Right. I think it depends whether you're talking about surgery or whether you're talking about radiosurgery.
Yeah.
With surgery, you've got to be fit generally for a general anesthetic because most of them are done as general anesthetic procedures. With surgery, there's always a risk in the brain of bleeding because the brain is very, very vascular, and you cannot afford to have bleeding in the brain because that creates its own set of problems. So that becomes particularly an issue with patients who are anticoagulated, blood thinning drugs, that sort of thing. Those considerations don't really apply to radiosurgery, but there may be other considerations. And at times, we would say that, a patient should think about surgery because there are advantages to it. At times, we'd think that radiosurgery is more attractive. At times, we'd explore those options, which might vary very much from a patient-to-patient set of thoughts. At the risk of taking you away from brain tumours, we touched on trigeminal neuralgia. There is an open surgical operation for trigeminal neuralgia. It remains major surgery. In talking to patients in a very, very established way, which makes it safe, but going into somebody's head is never 100% safe. But it probably offers the best chance of a permanent cure. The radiosurgery is a day case treatment. It puts the patient through much less. There's no protracted period of recovery, but there is a recurrence rate. Now, if the pain recurs, you can repeat the treatment. If it's worked once, we'd expect it to work again. But the more you treat the nerve, the more you cause numbness. And so you end up with a balance of risks and benefits. And different patients will decide on different courses of action for different reasons, depending, on not only on their own health, but perhaps if they're the carer for elderly parents or whatever, other factors come into this.
No, of course, absolutely. I mean, we know that anesthetists specialize in gamma knife radiosurgery. When is it used, and when is it, and is it safe?
Right. Well, I think that's really the three indications that we've touched on.
Okay.
In that it's used for tumours, it's used for vascular malformations, and it's used for functional conditions. Now, the safety record depends on what those tumours are, where they are, how large they are. But when you treat cerebral metastases, which are cancers that have spread from elsewhere in the body and gone to the head, if you don't treat them, those patients do very, very badly. So there's a risk in not treating as well as treating. When it becomes benign tumours, those risks have a different sense to them, and that can impact on treatment options. So it becomes different for each of the conditions depending on those issues.
Mm-hmm. No, of course. Is there any difference between like gamma knife ray surgery and other treatments of tumours?
Yes, and radiosurgery is not exclusively gamma knife. There are other treatment platforms that perform similarly. When it comes to intracranial tumours, and again, I'm going to generalize, which is perhaps a slightly risky thing to do, but, in providing a sensible answer, you have to. And what I would say is that a lot of chemotherapy agents penetrate the brain poorly. So they may get to other parts of the body, but the brain is protected by what's termed the blood-brain barrier. Because of that, the use of chemotherapy agents in brain tumours is relatively limited. And then you start to say, well, what are the other options? And I would divide those options into three, meaning surgery, conventional radiotherapy, and radiosurgery techniques, of which gamma knife is one. And I would say that they all have advantages and limitations. The big advantage of surgery is that you can take tumour away, you can create space, you can relieve mass effect. And a second issue is that it will provide tissue, and characterizing the tissue can be vitally important in managing a patient. The problem is that surgery typically has one direction of surgical access. So if you have a multifocal problem, you're starting to see limitations of surgery. And again, we've said that surgery is majorly invasive. Fractionated radiotherapy, conventional radiotherapy, typically targets a tumour and a surrounding volume of normal tissue. And it does that repeatedly with low doses that are repeated over a number of days or weeks. Now, it relies on the notion that the tumour is growing rapidly and is more sensitive and gets a cumulative hit from the radiotherapy, whereas the normal tissues have a chance to recover. And that's most applicable to malignant tumours. The more benign you get, the more the benign tumour is like the normal tissue. The notion of treating a normal volume around a target can, however, be useful, particularly if you've got a diffusely infiltrating tumour and you're not really sure where the edge of it is. And probably the range of conditions where that starts to feature are in the management of gliomas. Radiosurgery is almost the opposite philosophically of conventional radiotherapy, because you typically start off with a frame as a guidance system. You then image the patient and you're looking to precisely define the target or the tumour. And then you're also defining normal structures, particularly radiosensitive structures that you want to avoid. And then you're using the combination of the imaging and the frame to precisely direct radiation to your target and miss what you want to miss. Now, because of that, it's all done in a single day. It's not fractionated over days. At least typically, there are exceptions. And you're actually using the fact that you're targeting the disease and avoiding normal structures to increase the dose that you're delivering to that disease. And you're using the fact that you're typically treating a smaller volume as a result of it. So it's almost got the opposite philosophy. Now, because of that, you can use it potentially to treat benign tumours and benign disease as well as malignant disease. And because you can move the patient in the frame, you can treat multiple foci of disease, which makes it more flexible than a surgical approach.
No, of course. That's very interesting. We're just going to do a quick ad break and we'll be right back.
UK Health Radio, the station that makes you feel good. UK Health Radio, the station that makes you feel good.
Brain tumours, and really all tumours, can sound, quite frightening. Can you tell us exactly what they are?
Yes.
I know you've mentioned a few things, I know, but just a little bit more detail, that would be brilliant.
Okay. Well, again, I think the first thing to stress again is that we're talking about a wide spectrum of disease here. So it goes from the benign and the indolent to the malignant and everything in between. And the fact that you've got very different biological behavior means that they have very different implications in terms of how they impact on patients and what the treatment options are. So what the tumours have in common is a notion of a clonal proliferation. And what I mean by that is that all cells divide. And as they divide, the genetic messages, the DNA, has to be replicated or transcribed. And in that transcription, there is the potential for errors to be made, disturbing the genes and the gene function. Now, most of those errors do not matter, but some of them can critically affect growth control. And then you've got a cell that starts to grow up into a cell line and ultimately form a tumour. And the reality is that depending on the cell of origin, those tumours can behave very, very differently. So at one end of the spectrum is a tumour that's called a vestibular schwannoma, which is such a mouthful that people often refer to it by its old name, which is an acoustic neuroma, but they're the same thing. And they form on the inside of the ear and typically with time cause hearing loss, but on the side that they affect. So it's a one-sided hearing loss. Now, they can be very, very slow growing. So it may be very reasonable to what's termed wait and watch and just follow it with scans to see how much it's growing and how much it needs treatment. And those scan intervals are typically started at yearly intervals because the changes are very, very slow, and the closer you do two scans together, the harder it is to say anything about it. If there is growth, the old-fashioned approach would have been to think about surgical resection. Now, in talking about that to patients, that has much more risk of damage to the nerves that go to the ear and to the face that get to the face by going through the ear. It's also major surgery. And when it goes smoothly, probably people are in hospital for a week to 10 days, but they're probably off work for 3 months. It knocks them around with their sense of balance. It takes time for them to get better. And it's really, in part, that cranial nerve morbidity and that impact on quality of life and activities of daily living that has pushed the management of small to medium-sized acoustic neuromas very much towards radiosurgery. And again, you're back to the notion that it's typically a day case procedure. It's typically got minimal convalescence, if any. I generally say to patients that if they want a couple of days off work, I don't have a problem with it. But I know you can go around on an evening and see people tapping away on laptops and doing all sorts of things. So that's one end of the spectrum where we're talking about benign disease. And in talking to a patient, in reassuring a patient, I'm quite likely to say that, if they have to have a tumour in their head, an acoustic neuroma is one of the ones that they want to have because it may not need treatment. And if it does need treatment, there's a good minimally invasive treatment option. At the other end of the spectrum of biological activity are metastases or seedings that have developed from cancer elsewhere in the body. And probably the commonest of those are either lung cancer or breast cancer, because both of them are common cancers and commonly spread to the brain. And because they're spreading, they are malignant by definition. And it's known that without adequate treatment, they will progress. Typically, over weeks to months, they're aggressive. Now, where this is going is that we're increasingly asked to treat those patients, particularly if systemic disease is being controlled by chemotherapy agents, and you then get left with metastases in the brain. And that may not be curative. The cancer may develop and may escape control with time, but you can certainly buy some of those patients very valuable periods of time with a good quality of health. And as I say, that's a practice that has really developed massively over the last 10 years or so in the UK.
What do you think is the most difficult type of tumour to treat?
They're all different. I'm sorry. Going back to an acoustic neuroma, I had a patient referred, and he'd had leukemia as a child. And as part of that, he'd had a bone marrow transplant and a graft versus host reaction, which is a kind of immune reaction that had landed him on the ITU at the age of 12. And he'd had some sort of hypertensive crisis, this was all 18 years before he came to me, lost in the mists of time, which had left him bilaterally blind and deaf in one ear. And then 18 years down the line, as a total incidental thing, he started to lose hearing in his good ear, which was the one way he had of communicating with the outside world. And that's where he had his acoustic neuroma. So suddenly you've got very, very different issues in trying to manage his disability, because he has a significant disability from other events. Now, actually, what we did for him is we talked to very, very specialist audiology services, and we said that we didn't know why he was deaf in his bad ear. And we actually managed to give him back hearing on that side with a cochlear implant, which made treating his acoustic neuroma on the other side a lot easier and a lot safer. Now, that's an extreme example, but it's different for everybody depending on what the individual.
Right. I totally get that. I know you mentioned early on about, like, for example, if you've got lung cancer, it can spread to the brain. How does that happen? Because I have heard of that a number of times before, where someone might have a certain type of cancer. Right. Someone might have
the hallmark of a cancer is that it tends to spread. And so you will hear about a colorectal cancer, a gut cancer going to the liver. You'll hear about a lung cancer going to the bones or the brain. Breast cancer can go to the lungs or the brain. They have certain predispositions for spread. And to complicate things slightly, what we're now seeing with better systemic therapy is people developing cerebral metastases from cancers that previously would have killed them before the cerebral mets developed. So I treated a surgeon with metastases from a pancreatic cancer. You don't normally see that. So patterns are changing, but the notion is that they spread. The notion is that they spread through the blood.
Right, okay. We're just going to another quick ad break and we'll be right back.
UK Health Radio, the station that makes you feel good. UK Health Radio, the station that makes you feel good.
Thank you for that. Makes a lot of sense. The bloodstream basically is one method in which tumours can spread. In terms of signs to look out for, that are concerning or that where you may suspect something, are there any specific signs that people should look out for?
Again, a bit of a generalisation. If tumours present too much mass and occupy too much space, there can be symptoms of raised intracranial pressure, and they have symptoms like headache, but with particular characteristics. Conversely, if a tumour affects a specific area of the brain, it depends what function that brain does, and that is termed a focal neurological deficit or focal neurological effect. So it depends very much on where the tumour is.
Right, okay. I mean, how common are tumours?
Well, again, they vary massively depending on the type of tumour. So we talked about vestibular schwannomas. The incidence used to be put at 1 in 100,000 per year, so perhaps 500 or 600 cases in the UK. People say that it may be a bit more common with more imaging being available to find them. So these things are not absolute. The commonest tumour overall affecting the brain are metastases from cancers. The incidence of that has been put as high as 640 per million. But, a number of those patients may be terminally ill, and it may be a very late manifestation. So the incidence figures don't tell the whole story.
Right, okay. Do you have any patient success stories you'd be happy to share with us?
Right. Well, the first patient, and I'll give you two different vignettes really to kind of try and again show the range within brain tumours. The first patient would be the case that was reported by Amethyst that prompted this conversation. Okay. And she was originally referred 10 years ago, having had unilateral hearing loss. Only this was thought to be a meningioma rather than an acoustic neuroma, but it was forming inside the ear. When it was found, it was starting to press on the brain and distort the brain. And at the time, she was just short of 70. She was an incredibly well-educated woman and had her own strong views about various things, including the role of surgery and radiosurgery. And she chose to have this treated with gamma knife radiosurgery as a minimally invasive treatment. She was actually treated by my colleague, Andras Kemeny. Now, she remained well And 10 years later, she was still being followed up with scans to make sure that everything was controlled. But there'd been a delay with the COVID pandemic. So she had a scan, and actually the treated tumour looked to have shrunk somewhat, and there was now space between it and the brain. But on the other side, she developed a new separate tumour. Some patients develop neuromas, which is what this is falling into the category of. Now, to be honest, this was a much easier target because it was found when it was small, much smaller than the original tumour had been. But because she'd done well from her first treatment, because that was controlled 10 years down the line, because this had appeared over a 3-year period with the delays from COVID, she decided that she wanted that treating. We carried it out. She turned 80. She tolerated the procedure well, was discharged on the day of treatment. And it starts to give the feel for how you can manage an older, perhaps somewhat more vulnerable patient, because the older you are, the harder it is to recover from surgery, the harder it is to tolerate major surgery. But you're managing her with 2 day-case treatments over a decade.
She's done brilliant, isn't it?
The other case that I'd go to the other end of the spectrum, a little bit like the conversation earlier, would be a lady that I treated who was referred in her 40s with a complex visual disturbance. Now, she'd been diagnosed with HER2-positive breast cancer some 6 years previously. And that means that there's markers in the tumour that suggest that she's got chemotherapy options for the rest of her disease. She had a complex pineal mass, which was the cause of her distorted vision. And she also had 3 further lesions. Now, the pineal region is centrally located in the middle of the brain and is a very difficult and dangerous area to access. And this was extending beyond that because it was going down into the cerebellum. Now, we undertook a complex radiosurgery treatment, and that brought that under control. And 15 months later, she developed 2 further metastases in her head, which was a very simple treatment to do. And at 4 years, she had stable cranial imaging, although I think her systemic disease was becoming more of a problem. But the 4 years certainly allowed her teenage daughter to grow from being a very young teenager to being a very mature teenager, and was a very valuable period of time for them as a family.
Gosh, she's done really well to come out of that, considering age as well.
She's done, yeah.
For the first case study, but she was in 80 more or less.
She's now 80, yeah, and she's still tolerating it, yeah.
Gosh, that's brilliant. Have there been any unsuccessful stories, unfortunately?
Yes. Sometimes disease can be too extensive, particularly with cerebral metastatic disease. There is a condition that tends to be called leptomeningeal spread, and what that is that there's a fluid buffer around the brain. If cancer starts to spread there, it spreads very, very widely, and it's not really focal. And then that becomes something that cannot be managed with radiosurgery.
Right, okay. Are there any other types of treatment that can work on that kind of
area? That would depend on the tumour and what was available. Yeah.
Actually, another question comes to mind. In terms of, I know we might have already crossed it, and it's quite generalised, but no, I'm not going to ask. I think we've mentioned enough about it. That's fine. Treatment-wise, what's the future, do you think? Is there anything in the pipeline for treatment, something very new that we're not aware of at the moment?
I mean, treatments are evolving all the time. And probably the most exciting area is whether chemotherapy agents become smaller as discrete chemical entities, allowing them to penetrate the brain better. Along with that, there's been significant interest in whether there can be synergistic effects with a radiation treatment like radiosurgery, then potentiating the subsequent use of chemotherapy. So there may well be developments, and it is a changing field. And as I mentioned to you, we're now being referred at times patients that we think we'd never have been referred 5 or 10 years ago because treatments are changing.
Right. Okay. You know, when you talk to some of your patients, do you? There must be that mental well-being aspect as well, because I'm going to make a big assumption that, you know, when someone finds out that they have a tumor, in terms of them accepting that, have you noticed there's challenges in that area?
I think I'd probably express it a little differently. I would try and engage with the patient and offer them open questions to allow them to ask what they wanted. Now, you might get an elderly patient who is hit by a diagnosis and she just wants somebody to take her through a treatment day in a very supportive fashion. More commonly, patients want information. And then I think what you try and do is empower them to have the best information that gives them as much a sense of personal control in what clearly can be a challenging and frightening set of circumstances. Because, you know, we all take our health for granted when it's good. When it's not good, suddenly you feel vulnerable.
No, absolutely. Are there services you can refer people on to that are but maybe struggling with that aspect of what's happened?
I mean, I think, again, I would say that that's back to more the general oncology services with particular specialist oncology nurses. And that's where that support is probably best accessed because the radiosurgery side is a kind of specialist indication. And again, quite often in talking to patients, I'll sort of say, well, you know, for the last 20, 30 years, I've only looked after people's heads. The rest of you, you know, and patients understand that they've come to you for a specialist procedure.
No. Yeah, actually, I do see your point. Basically, let me to make sure I'm getting this right. Gamma knife radiosurgery, is it accessible to everyone? Or how can it be accessed?
Okay. It's very much a super specialist practice. So it will take referrals from neuro-oncology services, from skull-based services, from vascular neurosurgery services. We talked about vascular malformations. Depends what the pathology is, but it will tend to take specialist referrals from that. Within England, the NHS England structure has a set of commissioning criteria. So the conditions that we've been talking about this evening are commissioned, but they may come with additional riders. So if we talk about cerebral metastases, there should be an intent to manage systemic disease actively. So if somebody's got a new diagnosis of a cancer with cerebral secondaries, we might treat the cerebral secondaries, but they'll be going on to treatment of the primary disease. There's an expectation that patients with that sort of disease would have a life expectancy at least of 6 months to make treatment worthwhile so that you're not treating somebody without a way forward. Those are commissioning guidelines. So there's a structure within the NHS to allow those treatments to progress. Commissioning arrangements may be different, will be different somewhat in Scotland, because NHS Scotland is a different organisation. NHS Wales, North Wales derives its neurosurgical support from Liverpool because there isn't a neurosurgical unit in North Wales. So it then starts to fall under the English umbrella. Cardiff have a way of referring patients. They have a gatekeeper designated neurosurgeon to facilitate those referrals. So there are ways through, and they would tend to refer into England and then follow more English guidelines. So yes, there is a commissioning power.
Brilliant. And where tumours are treated successfully, does that mean the life expectancy is not affected at all, or is there some limitations?
Again, it all depends on individual circumstances. But if you're treating effectively a benign tumour, you would be hoping and expecting that life expectancy would not be affected. If you're starting to treat malignant tumours, then particularly with cerebral metastases, there'll be issues about what's going on with the rest of the patient. Other conditions, there may be other factors. So when you get into pituitary tumours, you can have hormonal disturbance, and that can predispose to other medical problems.
If people are a bit worried or, about this area, or they want more advice on it or anything like that, is there a service, or can they come to you directly? Is there any way of getting more advice around it?
Referrals input comes through different routes. I think that most of our referrals come from other hospital specialties, and they become increasingly focused. Sometimes you'll get patients who have been struggling to find advice, and they'll have come to you with specific questions. Trigeminal neuralgia, again, is a good example of that. They may... It's kind of what we're talking about, trying to empower a patient. They may just want advice about what their treatment options are, so that they know what can be accessed.
Brilliant. Okay. And is there any websites people can look at for more information? I know you have the NHS, and I'm just wondering if there's anything else, if people need to do some reading or anything like that.
There's the NHS. There's a Sheffield Gamma Knife website that's based in the Hallamshire Hospital, which is the NHS hospital. There are various other associations. So there's things like the Trigeminal Neuralgia Association, which obviously is only relevant to the pain condition. There are different ways of accessing information.
And to be referred into your services, again, it's going for the normal mainstream services. Is that right?
I would say that the majority of services, quite a lot of the work that we do is in the Thornbury Gamma Knife is an overflow from the Hallamshire, and the two units work together. Most of those referrals will have come in from other specialist services, so they will be coming in with imaging and other information.
Brilliant. Dr. Rowe, thank you so much for your time today. It's been really helpful. And, any last piece of advice for anybody out there? Is there anything you'd like to say or anything like that? Or
I think the thing that I worried about with these questions and this talk was that people should not lump brain tumours all as one condition, because they're very varied with very different considerations.
Absolutely. Because everything's very different, isn't it? And also in relation to the person themselves and how they react to it.
And in relation to the biological behaviour of different sorts of tumour and what that means in terms of clinical options, rather than focused as one entity.
Sorry, Dr. Rowe, can you just repeat that? The reception went a bit down there. If you can just mention that again.
Sorry, right. Brain tumours are a diverse group. They're not really one entity. So people need to get information that's relevant to them rather than to brain tumours in general.
Brilliant. Thanks for that piece of advice. Makes a lot of sense.
Okay.
And thanks for your time today. And thank you to all our listeners as well. And you can find me at GavinJ417 on Instagram. Until next time, take care.